right, well, thank you, Melissa. I saw that you hit record. So we are getting to the top of the hour, so we will go ahead and get started. And as more people join us, that'll be great. So hi, everyone. I am Shamia Roberts, Director of the Viral Hepatitis Prevention and Clinical Services for the Tennessee Department of Health, and I'm going to be the facilitator today. Next slide. So today's agenda will include introductions and announcements, a few quick highlights from our last session, a few new updates, a didactic presentation about initial hepatitis C virus treatment selection for children by Dr. Clark Allen, one of our, also we will have a pediatric case presentation and then some closing remarks. First, some in-chat introductions, as well as some brief announcements. So before we get started, I would like everyone to take a second to introduce themselves in the chat. Please be sure to include your name, your role, your organization, and whether or not this is your first ECHO session with us. I see a couple, there we go. I'm starting to see introductions, great. So a few quick reminders. I want to highlight that you may have been, you kind of may have seen the session when we joined, the slides when we joined, I'm sorry, the sign-in. So I need everyone, including subject matter experts and our TDH team, to go ahead and take 2 minutes to complete this sign-in sheet. You can utilize the QR code on the left-hand side there, I'm sorry, right-hand side, which will be put in the chat, or you can, I think Lindsay actually just dropped the link in there as well, so you could use the link from the chat also. There it is, perfect. The sign-in sheet is required for our accrediting body, and it is the only proof that we will have of your attendance as far as they're concerned, so it's really important to complete the sign-in sheet. You will not be eligible for CE without it, and even if you do not want the CE, we will need you to complete it, please. So I'll give everyone just a minute to do that, and as you do it, if you don't mind to provide a thumbs up to let me know you've gotten signed in. There we go. I'm starting to see some thumbs up. Perfect. And I don't believe Dr. Chastain joined us today, but typically we do have someone with the Southeast Age Education and Training Center with us. And I think Clover, I think I saw that you are here. So they, of course, Dr. Go ahead.
If you want me to do the spiel, I'm totally capable.
Perfect. Do it.
Wonderful. Yeah, so hi everyone. I'm here representing sort of both the Southeast AIDS Education Training Center, but specifically the Tennessee AIDS Education Training Center. So we help coordinate some of the subject matter experts who've been helping out with the ECHO training, specifically usually Dr. Chastain. And we actually have a separate registration link that we use. I just dropped it in the chat. That helps us when we're reporting back to HRSA, keeping our grant funding. And so I'd be very appreciative if you would also take a second and click that link and fill it out. And if you don't have an account on the AUTC website, it's totally fine. You can always circle back to it later. Thank you.
Thanks, Clover. We will go ahead and go to the next slide. All right, so please turn on your video and mute yourself unless speaking. Feel free to come off of mute to ask questions though. We are welcoming questions. And then Anastasia, did you notice that anyone joined via the phone?
Nope.
Please never discuss PHI and please treat everyone with respect. So let's dive right in. I would like to highlight a few important things we discussed at our last session. So in February of 2022, the CDC released universal hepatitis B virus vaccination recommendations, stating that all infants, persons aged less than 19 years, adults aged 19 to 59 years, and adults aged over 60 years with risk factors for hepatitis B should be vaccinated against HBV. CDC also specified that adults greater than or equal to 60 years old without known risk factors for hepatitis B may receive hepatitis B vaccines as well. So essentially, it's universal vaccination now. Next slide. Last month, CDC released updated screening and testing recommendations for hepatitis B as well. These recommendations shifted away from the risk-based testing to universal testing, which aligns with those 2022 universal hepatitis B vaccination recommendations. So now all adults over the age of 18 should have screening performed for hepatitis B surface antigen, antibody to hepatitis B surface antigen, and total antibody for hepatitis B core antigen. So that's what they're calling a triple panel screening. And Lindsay is putting some links in the chat for us if you all want to check those out with some additional information about these updated recommendations. Part of the updated testing recommendations is all pregnant persons should be screened during each pregnancy, preferably in the first trimester, regardless of vaccination status or a history of hepatitis B testing. And then regardless of age, all persons with an increased risk for hepatitis B should be tested, and routine period testing should be conducted for all adults with ongoing risk factors regardless of age. So for our health department folks on the call, a new nursing protocol reflecting these changes, both the universal vaccination and universal testing, is currently being considered and actively discussed. So updates regarding a protocol will be coming from the Community Health Services group, but we wanted to make sure that everyone was aware of these new national recommendations. Also, an exciting new update I want to make everyone aware of. Next slide. So the White House is proposing the allocation of $12.3 billion for a national hepatitis C elimination program. This is a 5-year initiative focusing on 3 main priorities and projects and projects significant cost savings as well, and going to be related a lot to the prevention of liver failure, liver cancer, and other comorbidities. It's a 3-pronged approach, really. The first being hepatitis C point of care testing. So diagnostic HCV tests are already available in other countries. So the hope is to leverage the rapid acceleration of diagnostics initiative that was established during COVID to expedite the emergency use authorization process to gain rapid approval for those point of care RNA tests. So that would be very exciting. The second piece of that is expanding access to hepatitis C medications. So establishing a national subscription model would be part of this. This is similar to what they're calling the Netflix model, currently being used by the state of Louisiana, as well as a few other states. Essentially, the federal government would negotiate a fixed price with drug manufacturers to ensure widespread medication availability. This proposal also asks for additional copay assistance for Medicare clients, and then also is asking commercial insurers to really increase the hepatitis C testing and treatment coverage as well. The last piece of this is supporting increased testing and treatment access. So this includes support of prevention services, including increasing screening, strengthening linkage to care programs and case management, exploring the development of hepatitis C vaccinations, and increasing the number of treating providers through innovative health methods such as Project Echo. Project Echo is mentioned several times actually by Dr. Collins and others. And I see Lindsay put the link in the chat that gives more information about this initiative. So really exciting things going on within the world of viral hepatitis. Before we move on, any questions about those universal hepatitis B recommendations or the proposed hepatitis C elimination plans? And feel free to come off of mute and give your thoughts or comments or questions. Okay, I don't think I'm seeing any hands or anything. We can always ask questions later too if you're thinking of them. So with that, I'm going to turn it over to Dr. Clark Allen to provide our didactic today. Dr. Allen, please go ahead and say next slide when you're ready for us to advance the slides.
Okay, sounds good. Thanks, Mia, for that introduction. So yeah, I believe this is one that we've all been waiting for. We've been building up to this, looking at all of the different lab testing and things to evaluate before hepatitis C treatment starts. And now we've finally got to the point where we're ready to talk about the medication. So let's go to the next slide. No financial disclosures. I'm not affiliated with any of the drug companies that dispense medications for the treatment of hepatitis C. Next slide. So the main goal of hepatitis C treatment, as you might guess, is there is a cure for it. We can completely get rid of, eradicate the hepatitis C virus out of each individual who is infected, which is great news. That way we can share that news with individuals. Hopefully that motivates them to want to take the medicine appropriately and effectively. The main lab test that we're looking for is a hepatitis C viral load not detected. It matters about timing. We want to make sure that we're checking this viral load once at baseline and then once at least 12 weeks after they're finished with the medication course. So it's always important to know when the patient started and also when they finished. We want to make sure that we want to promote 100% compliance. Inevitably, some patients will not be 100% compliant, and we will still want to know when they finished to then schedule that final appointment 12 weeks after therapy. So you'll hear us say a lot, SVR12 stands for sustained viral response 12 weeks after treatment. So that's the cure determination date. If it's hepatitis C not detected at that time, then we can say for sure they're cured, and then follow-up can be as needed if there's any risk factors going forward that may put them at risk of potential reinfection. Things that we're trying to avoid by treating hepatitis C. So I tell my patients that this is kind of preventative medicine for preventing future long-term complications associated with their liver. So the main reason I emphasize is we're trying to avoid liver cirrhosis if they don't already have it. For infants and pediatrics, I don't expect them to have any cirrhosis. We're also trying to avoid liver cancer as well as end-stage liver disease. Those are things that I want to emphasize on the front end to kind of get them. I feel like they will listen to me more if I say the word, we're trying to prevent cancer by doing this. So that's one of those keywords that I make sure I emphasize during my counseling sessions. Liver transplant, it can also prevent that as well, which would be something associated with decompensated liver cirrhosis. Okay, next slide. Now we've got a simplified treatment algorithm for pediatrics without cirrhosis. I want to make sure we clarify without cirrhosis. This has been designed with Tennessee Department of Health. I believe Dr. Alfaro Cruz and Dr. Talley have reviewed this and been associated with building this schematic. Next slide. I believe Lindsay can post the link to this in the chat. There's lots of things on this slide. Just want to make sure it be known that there is kind of an algorithm that each one of you can utilize and print out and have at your practice site. That way you can go through these steps to kind of make sure you're going through all the proper steps to evaluate each hepatitis C patient individually, making sure they're included in the simplified treatment algorithm or they're not, if they need to be referred to a specialist if they are not qualifying for the simplified pediatric treatment process. Next slide. And then, so now we want to know who and when is indicated for treatment. So the main thing with pediatric patients will be their age and then also their weight. So we can go to the next slide. So the main agent that we'll be using for the treatment of hepatitis C are called direct-acting antiviral agents. So we'll say DAAs going forward, recommended for all pediatric patients greater than the age of 3 years old. We want to treat early. We don't want it to delay. We want to emphasize the importance of trying to treat it as soon as they're eligible for it because of the risk of long-term complications in the future. We don't expect there to be any liver complications in pediatric patients, but there always can be that risk associated with it. So same thing in my clinic with adult patients. When we see them, when we get them into clinic, we want to treat them as soon as possible because we don't know how long it's been there. For pediatric patients, we will know that. We want to treat it to prevent any future long-term complications associated with the liver to be caused into the patient. This is beneficial to the child for their overall health and longevity of life. Also cost effective for the healthcare system overall because we're preventing potential hospitalizations and liver associated disease states going forward in the future. Patients who would not be eligible for the simplified treatment algorithm would be patients who have already been treated with a different agent. If they have cirrhosis, if they're co-infected with HIV or hepatitis B, if they've already had a liver transplant or hepatocellular carcinoma. Next slide. Now, this is going to be the main point of what I want to spend the most time on. This is, I've seen some kind of responses talking about a decision-making tree. So this is kind of the process of how I'm going to walk through each patient in my clinic as well as with pediatric patients. Next slide. So these are kind of the key factors for a pediatric patient. We first want to check their viral load. We want to know if they actively have hepatitis C. We want to look at their genotype, know which genotype 1 out of 6. We want to assess their liver fibrosis. There's numerous different ways you can check liver fibrosis, whether it be a FIB4 score, an APRI score, a FibroSure, or a FibroScan, which is the elastography. Any one of those methods are appropriate for staging the liver. We also want to know if they have hepatitis B, so we want to make sure that any co-infected patient, because there is a risk for reactivation of hepatitis B with a patient who's going to start on hepatitis C medication. So we want to know who has hepatitis B before we start. So those are things to evaluate from a laboratory standpoint. Then you want to look at medications. What other medications is the patient currently taking? Are there any interactions with the medications for hepatitis C? There are medications out there such as heartburn, such as seizure, HIV medications, anticoagulants. There are more. We will cover those more in the specific drug interactions echo session later this year. So I don't want to spend all the time on that, but there are resources, and we'll talk about that on the next slide. As far as patient demographics, we want to know that they're of age, 3 years old, and then we want to know their weight because we want to know that we're dosing the medication appropriately for each patient. Once we've kind of assessed those 3 factors, we want to look at insurance formularies. Some insurance formularies might prefer glucapavir pibrentasvir, trade name Mavyret, or sofosbuvir velpatasvir, trade name Epclusa. Potentially, they could also have on formulary ledipasvir, sofosbuvir, trade name Harvoni, and sometimes that can differentiate how to decide which medication is right for the patient based on their laboratory, their drug interactions, their demographics, and also their insurance. If there are no factors that are contributing to kind of narrowing therapy down to one agent at that point, then you can kind of open up to the patient to ask them if they have a preference on a shorter course that would require food or a longer course that would be just without food. So that could be also a potential factor in as far as evaluating each patient to know which medication is right for them, because we want to pick something that is appropriate for them as long as all options are on the table. So I wanted to make sure I spent plenty of time on this slide to make sure everybody kind of understands these are the different steps to kind of walk through with each patient case, making sure that you've done your due diligence to assess all of these factors for each patient. Next slide. Now here's my drug interaction slide. We've got several different options. I utilize 2 of them for the most part. They're the University of Liverpool drug interaction site. It's free to use. So I've got that one listed on the left, and that's kind of what a brief kind of overview of what it looks like. Also, if you have subscription to Lexicomp or Micromedics, you can also utilize those too. I usually utilize Lexicomp and Micromedics as I kind of just compare and contrast the different drug interactions that might occur. Sometimes they don't always align within the 3 websites. And so I do want to compare and contrast and then look and actually read into the details about what actually is occurring with the interactions and then make a clinical judgment call on if we need to switch to a different agent or continue with it with the physician's approval. Next slide. Now we want to talk about the medication. So I know that's what we've all been waiting for. So we can go ahead and jump right into the first agent. I believe it's going to be glucoprevir preventasphere. So we.
Dr. Allen, before we jump into that, I
Yep.
see a question in the chat
Oh, okay.
regarding treatment. So I just wanted to raise that question. So any considerations, this is from Wayne, feel free to jump in, Wayne. Any considerations regarding race or gender for treatment? Is that something that we need to think about?
Not that I'm aware of. It's usually just based on their age and their weight, and then if they actually have hepatitis C. Any follow-up, Dr. Alfaro Cruz?
No, not really regarding race or gender. I think we take more into account, as you say, the weight, the age, and the genotype. And I think you're going to talk about that on the next slide. And so I think we care more about the genotype rather than the race or the gender of the patient.
All right. Yes, great question. Thanks for asking, because we did not identify those patient demographics. Yeah, that's something that we do want to know, but not something that will dictate treatment options. Now, looking at the medications that are available for pediatric patients for treatment of hepatitis C, we've got glucoprevir preventasphere, which is trade name Mavyret, weight-based dosing. It's 8 weeks. It is with food. And then the other two agents, sofosbuvir velpatasvir, trade name Epclusa, it's for 12 weeks, no regard to food. And then we've got ladipasvir, sofosbuvir, trade name Harvoni, which is only for specific genotypes of 1, 4, 5, and 6. It's also for 12 weeks, no regard to food. So notice how I'm differentiating those two to give patient preference if they have a preference on shorter course with food, or if they prefer the longer course without food. We want to give that option if all the other demographics and patient factors are on the table. Next slide. So let's start off with the shorter course, glucoprevir preventasphere, trade name Mavyret. Here are the dosing algorithms based on weight. So less than 20 kgs all the way up to greater than 45 is a full dose. So anybody over the age or anybody over the weight of 45 kgs, they would just get the standard dose of glucoprevir preventasphere, trade name Mavyret, for their dose. Next slide. So this is kind of, I wanted to make sure I got a photo of it to kind of give an example of what the pellets look like for pediatric patients. It is pangenotypic, genotypes 1 through 6. It's in these oral pellets, so it's 50 milligrams per 20 milligrams for each packet, and then based on their weight, you'll dose it accordingly to their weight to give them the proper dose. It prefers to be taken with food, as I specified. It is a protease inhibitor. Most protease inhibitors do require food for correct absorption. And they were very specific on recommending certain foods, not just any food. They wanted to make sure it's a food that's sticky, that can stick to a spoon. And they gave examples of peanut butter, jam, Greek yogurt, something like that, where I believe the pellets can stick to it. And then the infant child can consume it and just by swallowing. You don't want to chew the tablet or chew the pellet, excuse me, because they will be very bitter to the taste. So that's something that's going to be probably the hardest counseling point for each infant, is not to chew the pellets. So that'll be something that'll be universal for all 3 agents. Side effects are very minimal, maybe headaches, maybe some fatigue in the first couple of days. I don't expect those side effects to continue throughout the treatment course based on my experience with adult patients. Next slide. So now let's move to the next agent, sofosbuvir velpatasvir, trade name Epclusa, also has a dosing strategy of less than 17 kgs all the way up to greater than 30 kgs is a full dose of Epclusa. And it can be in pellets, but then it can also be switched over to tablets depending on patient age. We would have a conversation with that patient whether they want to do pellets or they wanted to do the adult dose tablet. Next slide. It's also a pangenotypic agent. It also is oral pellet. So I got a different visual on this one, where this one can be with or without food. So you can apply. It doesn't specify whether it has to be with a sticky food or anything. It just says it can be taken with food. So that one, it didn't give kind of restriction on that based on the same with Mavyret. Same goes, do not treat the tablets. Side effects are universal. But this one, it mentions GI side effects, and that usually is contributed to. This one can be with or without food. I usually tell patients who are experiencing GI side effects like nausea, vomiting, upset stomach, maybe diarrhea, I'll tell those patients to take it with food, and that usually helps alleviate those GI side effects. Next slide. Now we've got to our final agent, ladipasvir, sofosbuvir, trade name Harvoni, very similar to Epclusa as far as a dosing strategy with less than 17 kgs all the way up to greater than 35 kgs on the different dosing schemes of the three. I guess, standard dose or full dose of adult dose is the greater than 35 kgs. Next slide. This one's only approved for genotypes 1, 4, 5, and 6, also in oral pellet formation. I've got two different pictures here. Those are two different strengths. So each strength has its own pellet form. So that's why you make sure that you've got the right weight. That way you're filling out the paperwork with the insurance company to get approved for the right dose. So very specific on those things. Oral pellets, don't chew them, can be with or without food, just like with Epclusa from the last slide. Same side effects as with Epclusa, maybe some headaches, GI issues. If you're having GI issues, take it with food. And fatigue has also been reported with this agent. Next slide. Now, once they've got on the medication, the most important thing I tell my patients is once we start the medication, we want to complete the course without any missed doses to give us the best chance of cure. About 98% effective at curing hepatitis C. That's if you take it every single day. So I really harp on them in the initial counseling points to take it every day, treat it like an antibiotic course, that you're taking this medicine to get rid of the hepatitis C. And if you take it every day, you're getting rid of it every single day. So I try to just drill home that point to make sure that they're aware of the importance of this, and then also remind them of those long-term complications that we are preventing in the future. Always want to, when we see them in clinic, do a medication reconciliation, making sure we're monitoring new drugs or any drugs they stop, making sure we've always got accurate medication list for the patient, monitor any adverse effects or side effects with the medication. If they're on an anticoagulant, we want to monitor their INR, their international normalized ratio. There is a potential it can fluctuate on a hepatitis C drug plus an anticoagulant. So that'll be something to monitor. It's not something that you would want to steer clear of it. Just want to monitor it and make sure that you're aware that there might need to be a dose adjust if that were the case. Also, potential risk of hypoglycemia in patients on diabetic medications. So just be mindful of those two key counseling points for patients who are on medications for those two disease states. Also, we have patients come back at week 4 and check a viral load, make sure we can assess while they're on the medication. We like to see them in clinic, check their lab work while they're on the medicine, make sure everything looks great. We expect there to be a dramatic decline in the viral load, almost next to nothing, but not exactly completely gone. And then that way we can encourage them, let them know that we are on the right track. Medication's working to get rid of the virus. So those are and then of course we'll make sure we schedule that final appointment for SPR 12 weeks after they're off the medicine for that final cure determination date. Next slide. I think that's it. Any questions about the subject or the material for today? I know I went through a lot. The main thing to remember is the decision tree, the 5 factors, making sure you're assessing all 5 of those factors when going through each pediatric case.
So I'm not seeing.
Go ahead.
Yeah, no, thank you, Dr. Allen. I'm not seeing any hands up or anything in the chat, but I do have a question. When, to anyone really, when you are mixing the medications and things like yogurt and such, I think I've seen parents have a tendency to like put it in a whole cup of yogurt, and then your kid's like, I'm not that hungry, I don't want all the yogurt. So I loved that you mentioned like a spoon. So do you think there's a big difference in, hey, we're going to take this spoon of it versus putting it in a large thing? Because I know my child, at least, sometimes we have a totally different attitude halfway through something and they're like, nope, not for me. And that would make it really hard to measure how much of the medicine they've taken. So any thoughts on that, or how you might counsel parents on that medication administration, particularly since you're telling them not to chew? Like, I'm not sure that all my kiddos would do that very well. Thoughts?
I'll let Dr. Alfaro Cruz.
Yeah, so I think, I try to kind of be more telling the parents that maybe use 1 tablespoon, 2 tablespoons, because the volume will make a difference. It's like, I always put this example, when you mix the Miralax and you mix it with the bottle, but the kid is not taking Miralax, right? Not finished the whole bottle, then you're not giving the medication. So as Dr. Allen mentioned, the goal is actually to take the medication. So I usually recommend just put everything in 1 tablespoon, make sure they're coated, meaning if you're doing applesauce, peanut butter, chocolate syrup, make sure they're coated so the kid cannot actually see them, because a lot of, especially 3 years old, they work in the terms of, if I see something there, I'm not taking it, right? And so the goal is for them to actually take it. So that's why I recommend just make sure they're not visible to the kid and try to give them as much as you can in 1 tablespoon or 2 tablespoons. Because if you just mix it along with the yogurt, with the little cups, there probably is going to be remaining of the medication. And I've had some cases where the parents say, oh, I was looking at a lot of these little pellets at the end. I'm like, that's not the goal. You have to take the whole thing. So that would be my most kind of say, no, let's kind of aim for 1 or 2 tablespoons, make sure they're coated so the kid, the 3-year-old cannot see them. Older kids is a little bit easier, but that 3-year-old who are actually very sensitive and they have like this sensory where they can actually taste if something is different or feel a texture different, then that's going to be the most important part.
And I see another question from Lindsay. Are the pellets small enough to mix with a substance and put perhaps in a syringe to administer to some of those younger kiddos?
Not really. I would not try to do syringe. I think the goal is, again, it's actually, they are small, but they can actually get stuck if you try to push them. So I would definitely not recommend doing syringe in this case. I'm seeing another one that is saying, is it okay for the pellet to be crushed into a powder? No, they recommend not. And I think you can probably help me more, but we usually don't recommend to get them crushed into a powder. There has been some cases that we may have to do it, but we recommend not to. And I'm going to let you give your opinion on that, Clark.
Yeah, I would just go off that the manufacturers do not recommend the patient to chew it just because there might be a bitter taste. I would imagine the same would probably hold true with if it were to be crushed. I bet that bitter taste would probably amplify. And then is the patient going to want to take that at all, depending on their age? If there's something bitter, that might make things harder for you to get the patient to take the medicine. So probably steer clear of that if we could.
That's really helpful. So another question related to administering medications. Has anybody noticed that has treated children that there's an increase in side effects in children? Do you feel like it's more common in some of our pediatric patients, or still pretty minimal with these DAA medications?
To be honest, there's not really that many side effects of medications, especially in children that I've seen. I cannot tell you in adults, but I can tell you in children, they really do not complain. The most common complaint that I get from the parent is that the kid does not want to swallow the medication, right? But usually side effects as nausea, GI issues, belly pain, vomiting, we don't see them as much in children.
So another question kind of related, what if you are giving the child medication and they feel it in their mouth or don't want to swallow it, like you said, and they're spitting it out? How do you redose, or now are we concerned about giving too much? What do we do about that?
In my case, I always recommend redose because if it's spitting up, I kind of talk to the parents the importance of actually doing full doses, and because it's a medication, it's not like a pill that you swallow the pill, you're getting everything. The pellets have all the composition of the medication. So if you are spitting up, if you're not swallowing, if you're only giving half a dose, then that is actually having significant impact on the dose that you're taking. So I always recommend redose if it's a significant amount that has been spit up.
Are there any concerns? I know sometimes if I give my kid, medication, I can't tell how much they've spit up or anything like that. Is there a time where you'd be concerned of if I give a full redose versus half of a redose? Any concerns about that, or would it not really matter every now and again occasion?
I haven't had that concern regarding, it's very few kids who actually we have to redose or ask them to redose. But even in those few kids, I have not seen significant side effects.
Really helpful. I see another question in the chat. Is genotype from Lindsay Zimmerman? Is genotype necessary if treating with Mavorite or Epclusa? I know certain insurances require this testing as part of treatment, but if treating a patient who is uninsured and cost of testing may be an issue or prohibited, is it absolutely indicated in pediatric patients to get a genotype?
So this is kind of a tricky question because for most of our patients who are insurance or who have TeenCare, they are going to ask you to get a genotype. Now, it is, as if you use Epclusa or Mavorite, it's not going to make a difference having the genotype. Most of our kids actually have genotype 1A. There's few that are genotype 2 or 3, but for those that are insurance, they will require you to have a genotype. Now, for those who are actually paying out of pocket that they're not insured, my recommendation will be treat. So don't waste your money. If these parents are paying out of pocket and are going to cost everything, you can choose Epclusa. You know, it will cover all the genotypes, and it can save them a lot of money if they don't, especially it's because it's mostly insurance requesting you to have the genotype.
So that's really helpful knowing that we have pangenotypic medications now, and maybe not always those restrictions, but TeenCare does require it.
And it's interesting because if Dr. Chastain is not here today, but he also mentioned that for adults, they usually are not asking or requesting getting a genotype. It's mostly in children who we do get those because it's kind of an insurance request from. But I think the more that we have these pangenic medications, the more probably we're going to start pushing away or moving away from getting genotypes.
Absolutely, that makes sense. What would you say are some of the concerns you hear most often from parents when they're first starting this journey with their child?
Most of the concerns that I usually is, one, is there going to be side effects? Two, can he do normal activity when he's taking this medication? Meaning, can he play? Can he go to school? And those are kind of, things that I always reassure them, even from the first appointment when we diagnose them, is yes, there can be some side effects. Usually I want them to kind of look for the first 1 or 2 weeks to see if there is significant response. So that way we can address any concerns. And two, I always tell them there's no limitation regarding what they're going to do. They're not more contagious. I always explain them that while they're getting treatment, because, sometimes the perception is, am I more contagious right now if I'm getting treatment done, right? And I tell them they are not, kids usually are not going to transmit to other people. You have to take care of universal precautions when you're dealing with blood and everything or secretions, but they're not more contagious or more infectious when they're getting treatment. So those are kind of the two main things that parents usually ask me about.
I really like that you covered being able to play and go to school and such. I think sometimes we want to put our kids in a bubble when we're concerned that things are going on. And I love that you talk about, no, we want them to still act like kids and be around other people and just use standard precautions. So that's great.